Hello, in this video I will present 10 questions on how to diagnose hyponatremia. You will still need to use your own clinical judgment, so don't blame me if the questions do not work for your patient, but they have helped me immensely in organizing my thoughts in a complicated hyponatremic patient. These 10 questions are based on the classic hyponatremic algorithm using the plasma osmolality, the volume status, as well as the urine osmolality. But to me, the algorithm is confusing and cumbersome, and I find most patients do not fit neatly into a box. But if this algorithm works for you, then God bless you, or I should say, God has blessed you. So this is Bob, and he is our 58-year-old male patient who has high blood pressure, and he's on lisinopril 10 milligrams once a day. He's a 30-pack-year smoker, and his blood pressure is normal, heart rate and respirations are normal, and he has a normal exam and no edema. And Bob presents today to the office for refills on his lisinopril and to go over his blood work, which is normal except for a sodium of 126. So we're going to try to figure out why Bob has a low sodium, and to understand Bob more, we need to understand that Bob is basically a beaker of water, or more accurately, a beaker of salt water, because Bob evolved from the ocean, and if Bob was into genealogy and he went back far enough in his family tree, he would find a fish. So Bob has a kidney that has a glomerulus and a proximal convoluted tubule and a distal convoluted tubule and a descending and ascending loop of Henle and a collecting duct to help maintain his sodium homeostasis. In order to understand Bob's lab, let's talk about a solution. A solution is basically a solute, sodium, divided by solvent, the water. So when we look at a sample of Bob's serum, we see sodium and water, and therefore we can get the concentration. Well, Bob has other solutes in his sample other than just sodium. He has glucose and protein as represented by the orange circles. So the solute, which in this case will be represented by the orange circles, the proteins and the glucose and the sodium, divided by the water, is going to give us our serum osmolality. Similarly, we can do the concentration of the sodium and the osmolality for the urine. So let's ask our first question. Is the hyponatremia an error? So we can repeat the lab test. Another possibility is that the glucose would be high, and the glucose would displace the sodium and therefore give a falsely low reading. We would know this by the fact that the serum osmolality is high. The second question is Bob on a diuretic? If he is, then the sodium, which is typically reabsorbed in the kidney, will not be reabsorbed, and therefore it will end up in the urine. So what will be our urine sodium typically if you're on a diuretic? And if you said that it would be high, you're correct, because we're going to have more sodium in our sample because it wasn't absorbed in the kidney. And similarly, if you have kidney disease, the sodium is not absorbed, and therefore it ends up in the urine. And what's our urine sodium now? It's going to be high, just like with the diuretic. So for questions 4 through 10, we will talk about antidiuretic hormone and renin and aldosterone. And to help explain this, we will use this runner who is sweating. I love to run, and for some reason I enjoy long runs on a hot day. And if I go for an 8-mile run, then I'm going to sweat on a hot day, and I'm going to decrease my plasma volume. And then there will be pressure receptors in my veins and in my atria and in my carotid sinuses. They're going to detect the decreased plasma volume, and ADH will be secreted into the blood. And then what happens? Well, here we are in the kidney, and the point of this slide will be that if my ADH goes up, then my urine osmolality should go up. So when I look at someone's urine and see a high urine osmolality, it shows that ADH is present. So you can see here in the urine that the water is trying to make it through the impermeable membrane, but it can't get through. So when we start to sweat, ADH is secreted by the posterior pituitary, and when it hits the receptor, that activates this vesicle to move and bring the aquaporin channel, which is right here, closer to the collecting duct membrane, and the channel will form an opening that the water can now go through. Aquaporin is a good name because it's water moving through a pore, and it moves through single file with one molecule at a time, entering the blood, hence correcting our plasma volume. So let's look at our concentration of the urine, and we've lost the water molecule, therefore the water has gone down, the solute has stayed the same, so our urine osmolarity will go up. So again, the point being that if you have ADH, then you're going to reabsorb water, and that's going to show up in the urine osmolality. So when the urine osmol is high, you know ADH is present. Got it? So let's go on to renin and aldosterone. We're back to our kidney, and when we're sweating, we're going to increase aldosterone because the pressure receptors are going to, in the kidney, are going to secrete more renin, which will eventually end up with more aldosterone, and the aldosterone will go to its receptor and activate the sodium potassium pump, and sodium will move into the blood. Water typically follows, and we increase our plasma volume. So now let's look at our concentration, and we're going to decrease the urine sodium because the sodium has moved out of the urine into the blood. So an increased renin aldosterone will increase the sodium absorption in the distal convoluted tubule, and then we'll end up with a decreased urine, and therefore we know that renin aldosterone is working. So question 4 is basically the hypovolemic hyponatremia. Do we have a decreased volume? Are we dehydrated? I'll let you read the signs and some of the causes of dehydration. So when we lose plasma volume, like we just did here, then the sodium, the aldosterone's released, and then the sodium will be reabsorbed back into the serum, and there'll be less sodium in the urine. When we measure the urine sodium will be what? And if you said that it'll be low, then you are correct. The 5th question is excessive volume. And this is the hypervolemic hyponatremia, where the typical causes are CHF, cirrhosis, and ascites. So in these conditions, there's a pressure or low volume phenomenon going to the kidney, so the kidney thinks that the body is low on plasma volume because it sees the low pressure. So it activates the renin-angiotensin system. Aldosterone is secreted, which, as we know, will then increase the amount of sodium reabsorption from the urine into the serum, and then we increase our serum volume, which we can see clinically with edema and rales. And then when we measure our urine sodium, just like with the dehydration, although we're volume overloaded in the body, but still in the urine sodium, we will still see less than 20. So what about excessive water intake? Well, the water has to go somewhere, so the kidney correctly excretes it, and therefore this will cause a low urine osmolarity because we have more water compared to our solute. What if we had someone who had a low solute intake? Then we would have less solute, and therefore we would measure a lower urine osmolarity. The following questions have to deal with increased ADH because hypothyroidism, adrenal gland pathology, and the symptom of inappropriate antidiuretic hormone excretion. Increased ADH is going to work on the collecting duct, and that's going to reabsorb more water out of the urine. Well, what about the urine osmolarity? We've already gone through that this will be high. So we look at these numbers and we see a low serum osmolarity? Well, we should be turning off ADH, but instead ADH is on, and that's not appropriate. So this brings us to Bob, who we asked to get further blood work and a chest x-ray and return and come back. And when he comes back, we tell him that the serum sodium is still 126. His serum osmolarity is low at 275, but his urine osmolarity is high. And we tell him, boy, that seems inappropriate because ADH shouldn't be present because your serum osmolarity is low, and we want this to be raised by decreasing ADH, but it's inappropriately present. So we go through our list, and he doesn't fit any of the questions except for when we look at his chest x-ray report, he has a lung tumor. So Bob has hyponatremia due to SIADH from a lung tumor. So this was a pretty straightforward case, and I hope to do other videos to present cases that are a little more complicated and to use our 10 question list to help us make the diagnosis and to go into treatment.